Good morning. It's a pleasure to welcome you to this morning's symposium. So we're going to be using a different format this morning, which is a fact or fiction type format to go through some of these slides. So before we begin, just some housekeeping items. This activity is supported by an educational grant from Synovian, and it's jointly produced by the North American Center for CME and CMEology. And I'm Jeff Strawn, one of the faculty this morning who will be talking about child and adolescent aspects of bipolar disorder and specifically bipolar depression. And I'm joined by my colleague, Dr. McIntyre from Toronto, who will be talking about the other end of the age span. In terms of disclosures, we'll go over those momentarily, but we will be talking about a number of off-label indications, specifically around treatment of pediatric bipolar depression. You have in your handout the agenda for this meeting, so I won't spend time going through that. And you also have copies of the learning objectives, so again, I won't spend time belaboring those. So with that said, let's move into the presentation. We're going to be talking about contemporary strategies for evidence-based treatment of bipolar depression in children and adolescents, but at the end of the presentation, we'll actually be spending some time reviewing the data related to mixed episodes in children and adolescents. In terms of my disclosures, they're listed as follows. I'll try to emphasize any that are potentially directly related as we move to the relevant slide. Among adults with bipolar disorder, about 30% had onset during childhood, fact or fiction. Press button 1 for fact, 2 for fiction. All right, so the majority of folks thinking that it does have its onset in adolescence for about a third of patients, and we'll actually review those data in a few moments. All right, so in terms of bipolar disorder in children and adolescents, one of the things that's really important to remember is that irritability is often a hallmark symptom of not only unipolar depressive episodes, but also depressive and manic, as well as formerly known as mixed episodes in children and adolescents. And this is a specific core symptom that has been linked with specific poor prognosis in these patients. Also, earlier onset, as one would expect, is associated with worse outcomes later in life. And finally, bipolar depression is more common than mania, particularly in the younger patients, including some of those prepubertal patients. Now, in terms of depressive episodes in the pediatric population, they're frequently missed. Now, again, this is probably something that seems intuitive to us in that often we have a number of externalizing symptoms that characterize a manic episode, whereas we see more internalizing symptoms associated with the depressive episode in many of these youngsters. Now, again, I don't want to spend a lot of time reviewing DSM criteria, but just to call your attention to the fact that irritability in the pediatric population, as you recall, is a depressive equivalent in depressive disorders such as major depressive disorder and also depression associated with bipolar disorder. Also, with regard to weight loss and decreased appetite, in the pediatric population, we can have a failure to meet expected growth milestones. Also, bipolar disorder in children and adolescents is frequently misdiagnosed. And there are a number of reasons for this, one of which is that ADHD is, quite frankly, much more common in the pediatric population. And particularly when we're dealing with severe patients, or severe cases of ADHD, wherein there's often tremendous impulsivity, irritability, as well as syndromically overlapping symptoms, it makes sense why we may consider this to be ADHD rather than bipolar disorder. Also, bipolar disorder in the pediatric population has greater clinical severity than unipolar depression. And last, we're not going to spend a lot of time going through the neurobiology, although certainly I would love to spend more time on this, but it's generally characterized by disruptions in amygdala prefrontal circuitry. And we see this both in terms of our neuroanatomic studies, but also in terms of our functional connectivity studies. Now, moving forward to treatment for pediatric patients with bipolar disorder, a number of advances have actually been made in recent years. Now, some of these medications that you actually see on the slide were grandfathered in, although over the last 2 years we've actually had some developments that largely were spurred by the Best Pharmaceuticals for Children's Act, passed and actually implemented by the FDA. So this is probably one of the very few situations where we actually have federally funded studies that have given rise to an FDA indication for a specific medication. And the hope is that this would be the case for many other medications down the road, not just psychotropic medications. In that regard, lithium was approved for additional indications in 2018 based on 2 studies which I'll review with you. Now, in terms of acute depression associated with bipolar I disorder in children and adolescents, there's a tremendous unmet need in terms of not only the evidence base, but also in terms of FDA approval. So at this point, we essentially had the Olanzapine-fluoxetine combination and Risperidone, although we'll talk about another treatment as well. And with regard to longer term or maintenance treatment, we have essentially lithium and Aripiprazole. And again, I'll show you those data as we go through. Now, this talk is primarily focused on pharmacologic interventions, and we'll be talking about those specific moieties on the left-hand side of the slide, but I wanted to just underscore the importance of non-pharmacologic interventions, not necessarily as monotherapy in patients with bipolar disorder, but certainly as adjunctive interventions. And when we look at longitudinal data, what we generally see is that those patients who are treated concurrently with psychotherapy, age 10 to 17, have much better outcomes. We also see that functional impairment is improved in many of these patients who receive adjunctive interventions, including family-focused therapy. So our next fact or fiction, in children and adolescents with bipolar disorder, antidepressant use is associated with poor tolerability and increased manic symptomatology and suicidal ideation. Fact or fiction? All right. So I think this response has actually shifted dramatically over what we would have seen had we shown this slide 5 or perhaps 10 years ago. I'm certainly very impressed with this, and we'll actually go through some of the data momentarily. All right, so manic symptomatology and suicidal ideation are significantly associated with antidepressant use in pediatric patients with bipolar disorder, and we actually see that that may even be the case in some of these youth who are at risk for developing bipolar disorder, as we'll talk about momentarily. So in terms of antidepressants for depression associated with bipolar I disorder in youth, we're going to go through a few of these studies. The first is a retrospective small study, about 60 kids, done by Joe Biederman and colleagues in Boston. And in this study, SSRIs were certainly effective or seemingly effective for acute bipolar depression. However, there was a significantly higher likelihood of relapse into a manic episode or likelihood of exhibiting treatment-emergent manic symptomatology with a relative risk of about 3. Now, in terms of looking at these data, published more than a decade ago, so again with DSM-4 diagnostic criteria, including bipolar disorder NOS, what we see is that among patients who are less than 17 years of age who are treated with an antidepressant, we have significantly higher likelihood of negative reactions as well as mixed or manic symptoms and new onset suicidal ideation. Now, this is a study which is one of the few that actually looks at youth who had a family history of bipolar disorder. So they're genetically predisposed to developing either affective disorders or specifically bipolar disorder. And in the study, we followed youth for a period up to about 5 years. Now, they couldn't have manic symptoms at baseline. They couldn't have a mood episode at baseline, at least in terms of bipolar mood episodes other than major depressive disorder. They certainly could have anxiety disorders, primarily generalized separation and social anxiety disorders. and we treated them naturalistically. But we followed them every 2 to 4 months over time and carefully evaluated mood symptoms over each week during the 5-year period. And what you see here is that most of the youth over this follow-up period exhibited some adverse event. Now, the likelihood of discontinuing antidepressant treatment as a result of an adverse event was significantly higher as you move to younger patients. So younger individuals who are at risk of developing bipolar disorder seem to have a higher likelihood of these treatment-emergent adverse events. And what you see here is our quartiles represented in this graph. Now, the first study that we're going to talk about looking at a medication for the treatment of bipolar disorder in children and adolescents is actually an open-label study. And this is a study looking at the Children's Depression Rating Scale score over time in children and adolescents age 10 to 17 who were treated with open-label lithium. And what we see, not unlike most open-label studies in psychiatry, is that there was improvement over time and that it was relatively well tolerated. That is lamotrigine. I'm sorry if I misspoke. So the next fact or fiction question, lithium is indicated for manic and depressive episodes associated with bipolar I disorder and maintenance in children and adolescents age 7 years and older. So most people thinking this is fact. It's a little bit of a trick question. In the next slide here. All right, it is actually fiction, and we'll talk about that here momentarily. So lithium is indicated for manic episodes and maintenance in pediatric patients with bipolar I disorder who are age 7 and older. We don't have a specific indication for depression. All right. Sorry, going back. So in terms of lithium for youth with depression associated with bipolar I disorder, we see in this study of about 27 kids that there was an improvement in Children's Depression Rating Scale score over time, not dissimilar from what we just talked about in the other open-label study. However, we're now going to move beyond some of these open-label studies. The newest data that we have with regard to the treatment of bipolar I disorder, at least with regard to maintenance in children, actually comes from that study that I referenced earlier that was sponsored by the BPCA through the National Institute of Child Health and Disease. And this is a study that actually looked at youth aged 7 to 17 who were experiencing a manic or mixed episode. And they received 24 weeks of lithium. This is the Lithium Collaborative Study called by the acronym COLT. Now, responders were actually randomized to either continue lithium or to be randomized to placebo for up to 28 additional weeks. And the primary outcome measure was discontinuation from the study for any reason, although they also looked at relapse of affective episodes, either depressive or manic or mixed. And again, I don't even know that we need to go into the statistics. I think these survival curves really tell the story in terms of the discontinuation here. But this is really the study that helped to give rise to that new maintenance indication for lithium in kids 7 to 17 in 2018. Now, the next study we're going to talk about is a study of Quetiapine in youth with depressive episodes associated with bipolar I disorder. And this is a study of kids aged 12 to 18 years of age, about 30 kids. And it's relatively small, probably somewhat underpowered to detect the difference in efficacy, but there was no statistically significant effect associated with treatment here. Now, the next study, which was a little bit larger, although probably associated with a number of limitations given that in terms of number of sites and significantly higher placebo response rate. But this is a study that included children and adolescents with bipolar I or II disorder. So again, very much following what was done with the adult Boulder trial. And what they looked at, like we've seen in many of these prior studies, is the change in the Children's Depression Rating Scale score. And what was observed was that over time there was no significant difference between groups. Now, the next study, actually one of the ones that we'll talk about that's positive for pediatric patients with bipolar depression, is a study of the Olanzapine-fluoxetine combination. Now, in this study, what was observed was that there was relatively early separation from placebo and that there was continued improvement over time. However, in a moment, we'll talk about the tolerability associated with Olanzapine-fluoxetine combination. And as we would expect, given the olanzapine component, there was actually sequoian weight gain associated with olanzapine. More than half of the patients experiencing significant increases in weight. And there was also probably what would be expected in terms of the metabolic tolerability with regard to triglycerides, although that really not quite hitting the 5% significance threshold. Now, the next study that we'll talk about is one of Risperidone. And this, again, like most of the other studies that we've looked at, has looked at the change in the children's depression rating scale score over time. And what we see here is that relative to placebo, there's improvement, and it becomes statistically significant at the week 2 time point. What we also see is that there's continued improvement over time. The other thing that I think is important here is that while the placebo response rate is larger than we see in some studies of unipolar depression and certainly of pediatric anxiety disorders, it's not the same placebo response rate that we see in many of these other trials in pediatric patients with bipolar depression, for example, the Quetiapine study that we talked about. And probably that difference in placebo response rate is really what allowed us to see a treatment placebo difference in effect. And so again, you see that this improvement continued to increase over time. Now, what I think is interesting here is the mean dose of Risperidone, which was around 30 milligrams per day. Now, in terms of looking at the tolerability of Risperidone in this double-blind, placebo-controlled trial, patients, after completing the initial portion, were followed over time in the context of open-label treatment. And what we see here is that there was maintenance of that improved effect, although this does come with a number of the limitations associated with open-label trials. Now, also as part of the open-label assessment of Risperidone in the long term, a number of papers have actually looked at metabolic profiles associated with this. And in this study, which I think is interesting for a couple of reasons, they actually modeled the expected weight gain in this population based on Z-score and based on age, as well as sex and height and other variables that we generally have to consider in the pediatric realm that my adult colleagues generally don't have to deal with. So what was observed was that there were relatively insignificant differences with regard to the actual weight gain that was observed over this period and the expected modeled weight gain over this follow-up period. So you see a final difference there of 6.9 kilograms and 6.7 kilograms. Now, in terms of the metabolic profile, what was observed was that this appeared to be relatively metabolically neutral, or certainly less metabolically offensive than most other medications. There was perhaps some signal with regard to triglycerides, and again, very off-label. We've done some work in Cincinnati looking at the way in which omega-3 fatty acids may mitigate some of the SGA-associated hypertriglyceridemia. There were no significant differences with regard to hemoglobin A1C, and there were no differences with regard to hyperprolactinemia. This issue of hyperprolactinemia is particularly important in that a number of the medications that don't seem to be associated with as significant of hyperprolactinemia in adults seem to be associated with much more hyperprolactinemia in the pediatric population. We'll talk a little bit about that when we get into the mixed states later in the presentation, but that's certainly the case for Olanzapine, wherein we don't see as much hyperprolactinemia in adults, but we see very significant hyperprolactinemia in pediatric patients. So in conclusion, for most adults with bipolar disorder, the onset occurred during childhood. Again, I don't think based on the polling results that was really a surprise to anyone in the room. The early onset bipolar disorder is associated with poorer long-term prognosis and an increased risk for suicide attempt. Next, there are relatively few controlled trials. I think you've really seen all of them at this point in the presentation with adolescents with bipolar depression. And that negative reactions to antidepressants, regardless of whether they're SSRIs, SNRIs, or atypical antidepressants, things like bupropion, seem to be fairly common in pediatric patients with bipolar disorder type 1, as well as those who are actually at risk for developing bipolar 1 disorder. And to date, at least previously, we had limited FDA treatments for bipolar depression in the pediatric age range. Lorazepam, as you've seen, was the first monotherapy to demonstrate efficacy and tolerability for bipolar depression in youth. So with that being said, it's my pleasure to introduce my colleague, Dr. Roger McIntyre, who will be speaking about bipolar depression in later life beyond special population.
Thanks, Jeff.
Nope.
Thank you.
Thanks.
And thank you, Jeff, for your presentation. Good morning, everybody. Okay, just my disclosures here in the private sector, also in the government sponsorship of my research and activities in Toronto. Now, I'm going to speak to the topic of old age bipolar disorder, and perhaps a couple of general comments just to really start. During the last decade, one of the observations that's been made in this population broadly, that is the bipolar population throughout the trajectory, beginning with the type of patients Jeff would see, people I would see a bit later in chronologic age, is that we now know that a subset of people with bipolar disorder exhibit premature aging. So if the multiple choice question said, is bipolar disorder a premature aging disease, yes or no, you'd have to circle yes. And now, is that the case for every affected person? No, but that would be the case for some people. And I wanted to bring that up first because when we talk about persons who are chronologically older in life, well, first of all, as we get older, we define it later and later, but the point I'm getting at is that there's two ways to think about old age bipolar disorder. People who declare their first episode of mania after the age of 50 or 60, and where you put the line is frankly generated more by consensus than really a clear answer on that. But when you see someone who declares mania for the very first time over the age of 50 or 60, that is the clarion call to really, in fact, conduct a thorough neurological investigation. And if there was one takeaway message of the presentation, that is the takeaway clinical message. Because it appears as though that individuals who declare for the very first time a manic episode over the age of 50, they are much more likely to have neurological disease, and often it's cerebrovascular in its nature. The other part about this, which I think is relevant, is that the phenomenological presentation of old age bipolar disorder overlaps extensively with persons who declare the illness in younger years. And as you all know, 70% of people who have bipolar disorder declare the illness prior to the age of 24. So it typically is an earlier age at onset disorder. The phenomenology overlaps extensively, but those, in fact, who have a really, really sharp eye would notice that the adult who's in the older age range with bipolar disorder, on average, tends to have more confusional states, more cognitive impairment, and also has more irritability and mixed. Now, the last part, irritability and mixed, has almost become a orthodoxy in this field that the older adult with bipolar tends to be more mixed. And I'm not saying that's untrue, but what I would say is I think in 2019, if we conducted similar studies, I'm not so sure that the prevalence is going to be that much different anymore. Because what we've all observed, or many of us have observed, is that in people in their 20s and 30s, we're seeing a significant increase in the presentation of mixed. In fact, I wrote a paper recently, where have all the euphoric bipolar patients gone? We're seeing more and more of these mixed patients. So you can see some facts. I was told that everyone at US Psych Congress can read, so I'm not going to read the slide. But the point is that what percentage of people declare bipolarity after the age of 50? It's variably reported, but if you remember 10%, you're probably going to get full marks on that question on the exam. So 10% of people declare first. So just as a statistic. Now you can see some of the mentions here with respect to how it could be different. I did speak to this mixed phenomenology, but again, mixed phenomenology is seemingly more common in younger adults who have bipolar disorder, and we're not entirely clear whether the rate of mixed features is really that much higher anymore in older people. With respect to dementia, you know that the adult who has bipolarity, declared earlier in life, in their 20s and 30s, is at a higher risk of incident dementia later on, not only Alzheimer's, but other types of dementia. And the variable that associates with that risk, the hazard, is the number of episodes. So the more episodes of bipolar you have, the more likely that individual will present in a demented state. And I've been in this for a little while now, this area, and I've been quite struck now over the years, tracking many patients since my residency years, of adults in their 50s who are now presenting with Alzheimer's disease and so on. So very, very concerning. Now, on the issue of death, you know that the most common cause of premature mortality in the entire bipolar population broadly is cardiovascular disease. And for those interested, cardiovascular disease subclinical is actually detectable in pediatric bipolar disorder, which is obviously very concerning. This is a core lesion, if you will, in the disease state. So with that statement that cardiovascular disease is the most common cause of premature mortality broadly, it won't surprise you it's also the most common cause in the older age group. Let's not forget suicide, however, because suicide rates remain elevated in those people who are of older age. Said differently, the standardized mortality ratio, the risk of suicide in a person who is over the age of 50 with bipolar, either because they declared the illness at that time, or more commonly, they've grown older with the illness, is still elevated. So the suicide risk doesn't, in fact, reduce. One part about that dementia comment, we're going to speak to this, is the role of lithium. Now, I started off by saying that the adult who has bipolar disorder in declaring for the first time in older age is really the person you and I should be vigilant for any neurological, specifically cerebral vascular event. And that's something that I have found as a clinician that has often been the case. In fact, the literature would indicate that in fact, the majority of these people may have some type of cerebral vascular disease. Whether or not it is the proximate, in other words, the immediate cause of why they've declared bipolarity, is an academic question, but they certainly have higher rates of neuroimaging identified abnormalities. Now, I've tried to highlight with these red rectangles some of the rates of medical comorbidity. It's a bit of a busy slide. Onset less than 50, over 50. Rather than try to do a contortion to read the slide, perhaps in fact what I would say is, and probably nobody's surprised, that the rates of concurrent medical problems is staggering in this group. I would say that, well, it's staggering across the entire age span of this disorder, bipolar disorder, with cardio, obesity, metabolic being the most common co-occurring conditions. By the way, that's not just by chance. We now believe that the pathogenesis of bipolar disorder broadly is overlapping with the pathogenesis of cardiovascular disease, obesity, and diabetes. And on the topic of cognitive impairment, which is so pronounced, again, throughout this entire illness trajectory, but in the older age, it now appears very clear that obesity is not simply a concurrent condition with perhaps a shared pathogenesis, but obesity appears to be anti-cognitive. In other words, obesity in the bipolar patient is associated with much lower cognitive functions when compared to the bipolar patient who is of normal weight. And this has inspired a kind of a notion that we've been looking at where obesity does metastasize to the brain as a metaphor of the effectors of insulin resistance and inflammation that are hazardously affecting brain. So cognition impairment is well known in bipolar disorder. I remember not that long ago, cognition did not receive that much attention in bipolar disorder. We now see it as a deficit as part of the illness. It's still an open question whether cognitive impairment is also more likely to be identified in people who are at risk, that is, they're a first-degree unaffected relative, and there's some results that suggest that could be the case. But the cognitive deficits we're talking about are what I call the Fab Four. The Fab Four, not the Beatles, but the Fab Four is executive functions, attention, memory, and processing speed. And depends on the study. Someone might find one domain more affected than the other, but I think really it's the full group of these subdomains that are affected: executive functions, memory, attention, and processing speed. And these observations of cognitive impairment are not just replicated and certainly very robust, but what's particularly relevant to you and I, whether it's old age or younger age bipolar disorder, is that the persisting cognitive impairment is what's in fact mediating PROs, patient-reported outcomes. So let's look at this question, fact or fiction. Cognitive abnormalities in bipolar depression and MDD are similar in older patients. Okay. Similar, so majority say fiction. They're not similar. Let's go to the next slide if we can. Okay. Is there another question? Fiction, exactly. Okay, older age major depression and bipolar depression have different neurocognitive symptoms and degenerative outcomes. Okay, so this is in fact looking at cognitive impairment, and I think, to be perfectly blunt, the evidence would not allow us to say with the utmost of certainty that there's staggering differences between the two groups. But what is there tells a story that on average, the modal person who has bipolar disorder, not only in older age, but also younger age, is not only more likely to have deficits in one or more of those four cognitive domains, but the magnitude of the deficit would be greater. Moreover, if the person with bipolar disorder reports or exhibits psychosis, he or she is more likely to be cognitively impaired than the other patient with bipolar who doesn't have psychosis. So psychosis in bipolar disorder is a particularly interesting proxy of cognitive impairment. On a separate and parenthetical note, the genetic studies that have been conducted in bipolar disorder and schizophrenia during the last decade tell a story that Kreplin and many others told 100 years ago, that there's a genetic overlap. And for those who are interested, the bipolar 1 patient has a genetic architecture that more closely approximates schizophrenia. The bipolar 2 patient has a genetic architecture that more closely approximates major depression. And what's interesting is that the bipolar 1 patient who has psychosis has cognitive impairment that more closely approximates schizophrenia. So the genetics of bipolar disorder probably are marching in some similar direction as the genetics of cognition, is my message. Now, lithium was first isolated in 1817. This is an old drug. By the way, many of the medications we have in bipolar are fossils. Lithium, 1817, divalproex, 1882, carbamazepine, 1953. These are oldies. Now, lithium, we know, has an anti-suicide effect. That's well established and seems to be unique to that agent within the FDA-approved agents for bipolar disorder. The other part about lithium, and you've probably heard this, it does seem to forestall, maybe reduce the hazard of dementia. And this has been replicated in observational studies. There's been other work that has looked at the biomarkers of dementia, that is, hyperphosphorylated tau, as well as amyloid protein in adults who don't have bipolar but have been tracked forward taking lithium with mild cognitive impairment. And the readout was that lithium has favorable influences on these biomarkers. For those who work in the lab, they've been telling us for a long time that lithium reduces the oligomerization of amyloid and reduces tau phosphorylation. So there's a molecular story that gives us the reason to believe that these observations being replicated are in fact real. So that's a very important point about this lithium, along with anti-suicide properties. Now, when it comes to the guidelines in treating the adult with bipolar disorder in older age, I'm sure, like me, the great majority of patients you're seeing over the age of 50 or 60 who have bipolar disorder, they had the illness for many years. They've grown older with the illness rather than new onset bipolar disorder. So, to be blunt, there are not many studies that have been conducted in adults who have new onset bipolar disorder over 50. And frankly, relatively few studies have included people in bipolar clinical trials beyond the age of 65. Usually we seem to have a thing with 18 to 65 when it comes to mood disorder studies. So we have some people, obviously up to 65, and some studies have actually had eligibility criteria where patients can come in at ages higher than 65, but not a whole lot. So with that as the lengthy preface, we in fact do a lot of extrapolation. A lot of extrapolation, if it's been shown to be helpful in a 35 or 45-year-old, well, probably I'm going to go to that age in someone who is 65 or 70. And that extrapolation is pragmatic, but that extrapolation would be guilty of really having a relatively thin database or evidence base to support it. But I think pragmatism is going to win out. Now, there's been a number of different guidelines in the area of bipolar. By the way, I had no idea. We just recently submitted a review of all guidelines around the world that had been prepared looking at depression and bipolar. I had no idea there were over 200 guidelines. And it was one of those kind of things I said, I wanted to do this project, and then once I got halfway into it, it's kind of like swimming halfway across the ocean. I might as well just keep swimming. And so I was sufficiently masochistic to do this. Anyways, lots of guidelines, but not a lot on the old age bipolar. Now, when it comes to what treatments we would recommend, there's no question that the pharmacotherapy is cornerstone. I've said enough about the somewhat anemic database that's there with respect to studies delimited to people with new onset over the age of 50. That being said, in our clinic in Toronto, lithium would still remain mood stabilizer par excellence. It is the gold standard in younger people and in older people. The challenge with lithium is not so much the kidneys, the thyroids, the laboratory monitoring. Of course, that's an issue. The issue is that the type of patient who responds best to lithium, that is the patient who has stable, episodic bipolar disorder, often with family history, is a patient we're seeing less and less of. We're seeing much more chronic, unstable, rapid cycling, mixed, comorbid patients. And these patients respond to lithium. They absolutely do, but just less so, or less predictably so, than the stable, episodic, what used to be called classic bipolar disorder. So you can see some statements here about psychotherapy. Makes good sense. I would say particularly social rhythm therapy. I remember when I was a fellow, I worked at a nursing home for 2 years in the Toronto area, and I was asked to see adults, obviously in a nursing home, older folks who had bipolar disorder. They all had social rhythm problems, and they all were often very psychotic, actually. And these individuals clearly stand to benefit from these types of resetting of the Zeitgebers, in other words, resetting of the environmental signals of what time of the day it is, and trying to reduce the risk of delirium superimposed on their bipolar disorder, as well as, in fact, to offer a psychosocial intervention to benefit directly their condition. Now, I don't need to tell you that as you get older, there's changes in the metabolism, the handling of medications, the pharmacokinetics of medications. That's obviously very, very well known. And I think that when it comes to what we have in guidelines. Again, the guidelines can only guide you based on the evidence, and frankly, the evidence is not that robust for a lot of the treatments, notwithstanding life goes on. And you can see here, these are the Canadian guidelines, Quetiapine and Lorazepam monotherapy. Now, that is something I think is reasonable. Quetiapine clearly has difficulties in some patients with sedation and somnolence, but notwithstanding, we do have some studies with Quetiapine that included people who were over the age of 50, most of whom who grow older with bipolar disorder. Now, lithium and lamotrigine, I call those the two L's, they're next. It does appear to be the case that the risk of rash or cutaneous syndromes in older people is less so than people who are younger, which I don't think is a significant risk for most adults anyways. And I want to put a particular plug in for lithium. And the fact that lithium might have some of these anti-dementia properties is obviously an intriguing asset. The fact that it's an anti-suicide drug is obviously relevant, and the fact that it works is also relevant. I should mention that there's a general consensus that in people who are 60 to 80 years of age, lithium levels of around maybe 4 to 0.8 seem to be okay. Over the age of 80, many of us prefer to see lithium levels 0.4 to 0.7. And I want you all to be reassured that those levels are certainly very effective. Now, antidepressants, you know the concern with antidepressants, they can lead to switch or treatment-emergent dysphoria, irritability, sleep disturbance, and so on, and that's something one has to be cautious about. I was quite struck at how often, when I was at this nursing home, I was asked to see people who were delirious, when in fact they weren't delirium, they did not have an altered sensorium, they actually were often psychotic and often very irritable and hostile. And in some cases, this seemed to be temporally associated with being exposed to antidepressants in some cases. You can see some comments here about lithium. Obviously, with kidneys decreasing in function, one has to be cautious with lithium levels. But again, I do see lithium as a gold standard for many of these people, particularly people with more of a stable course. I talked about dementia. This is specifically Alzheimer's disease. I wanted to put that slide in because this is obviously very intriguing. And what we do know is that not only is Alzheimer's and other dementing disorders more common in multi-episode bipolar disorder, but the age at onset is much, much earlier. In other words, rather than see the early signs of Alzheimer's like mild cognitive impairment at age 60 or 65, we see it in many cases at 50, even 45 in some cases, so obviously extremely concerning. By the way, for those interested, there's a framework that's been proffered to really help us understand why the bipolar patient is so prone to elevated and early age at onset dementia syndromes. One is implicating inflammation, or what's called immunosenescence, or inflammaging. So the inflammatory process of bipolarity puts in motion a vicious molecular cycle that then results in changes in brain structures and function critical to cognitive functions broadly. The other one, which is also in the suspect line, is insulin resistance. So Jeff works in the pediatric area. Colleagues at McLean have just recently looked at first-degree relatives of people who have bipolar disorder. They seem to have insulin resistance, even though they don't even have bipolar disorder. And a good friend of mine in Toronto, Ben Goldstein, which I'm sure Jeff knows well, Ben has shown significant rates of metabolic syndrome, even in the pediatric population. There's something about bipolarity that seems to result in insulin resistance, often subclinical, and insulin resistance is a significant risk for dementia syndromes. You all know that, for example, diabetes is thought to account for up to 10% of all cases of Alzheimer's disease. Lamotrigine has been around a long time. This is an example of repurposing. So lamotrigine was derived from a drug well known in malaria called pyrimethamine, And lamotrigine has open-label evidence that it can attenuate depression in the bipolar patient. We have that data here. And the doses are not too dissimilar from younger people under the age of, say, 50, and ranges of between 150 and 200. The Quetiapine recommendation was based on some fairly, it wouldn't be called rigorous. This was post hoc analysis of some clinical trials done with this agent in people that were mostly younger in age. Notwithstanding, there was a subgroup analysis done in those 55 to 65. The doses you're familiar with, 300 to 600. For me, the issue has been more sedation and, yes, some of the metabolic issues. Lorazepam has been looked at in people 55 years or older. Lorazepam, we heard about in the pediatric population, has this evidence in older age without the burden of the sedation and without the burden of the weight and metabolic changes. So think about older age bipolar disorder in two ways. First, has my patient grown older with bipolar, or is my patient declaring bipolar for the first time after the age of 50? In the latter scenario, that is, in fact, the message to conduct a thorough neurological evaluation. Person perhaps has an underlying cerebrovascular disease process in place, and that may require its own separate focus and clinical attention. It also is not without our interest that the first episode bipolar over age 50, they tend to have very low rates of family history of bipolar disorder. And that introduces the very real possibility that maybe the biological type, the biotype of their illness is very different. And that's interesting academically, and what that means clinically is to be determined. Secondly, I do think, in fact, be cognizant of patients who are older who are presenting with psychosis, irritability, cognitive disorganization. These are more often reported in older age bipolar, but certainly not uncommon in younger age groups. And then we've walked through some of the their various treatments, and I guess we all would prefer prevention, and we hope one day we'll have cures, but it does suggest, at least the data, that lithium may have some preventative effects on dementia syndromes downstream. And clearly that's a huge issue for many of us in the room who track a lot of patients throughout the lifespan. And this, of course, is augmented with a very, very heavy dose of psychoeducation and, where appropriate, manual-based psychotherapy. Folks, thank you very much. I appreciate it. Thank you.
So we're now going to continue looking at mixed episodes associated with bipolar disorder, particularly in pediatric patients, and then we'll flip back again to the other end of the age span. So I'm going to continue what Dr. McIntyre was talking about with regard to lithium, and specifically looking at mixed states associated with bipolar I disorder. And this is a relatively recent meta-analysis published by another Canadian, Anne Duffy, and colleagues just last year. And what was observed was that relative to placebo, there was a significant difference, although probably not as clearly apparent there. However, relative to divalproex, there was actually no difference. And we'll talk a little bit about divalproex later, although to adumbrate here, divalproex in the pediatric population, at least with regard to bipolar disorder, has really failed to demonstrate any significant benefit in approximately a half dozen studies, including some open label studies that we've done at the University of Cincinnati. And it's, as you know, particularly difficult not to show an effect in an open label study, but we were able to do so. With regard to lithium versus risperidone, you see the data relatively clearly there. Now, the next study that we're going to talk about actually looks at Asenapine in pediatric mixed states. And this is a nice study for a couple of reasons, one of which is that it actually allows us to look at the impact of dose relative to control intervention, placebo. Although one of the issues when we tend to do that and we look at multiple doses is that we increase the likelihood of randomizing to an active treatment, which has the unintended effect of actually increasing our placebo response. So that's something to bear in mind when we're looking at many of these studies methodologically. That being said, what we see is that in this sample where almost 60% were exhibiting a mixed state, that there was improvement associated with Asenapine. Now, when we look at Aripiprazole in pediatric patients with mixed states, so age 10 to 17, this is a relatively large study, and what we see is that there is, again, a significant improvement over time, and this is another study like the last one that we looked at, where they actually evaluated two different doses, 10 milligrams and 30 milligrams, and what we'll actually see in this study, and we'll see in some of the subsequent studies that we're going to talk about, is that there are often dose-related differences in tolerability that we see in the pediatric population that are perhaps even more pronounced than what we see in adult patients. And so what we see here, as I just alluded to, is that the average weight gain was not significantly different for the 10 milligram dose, but numerically there is a higher weight gain expected with the higher dose. And that's something that probably is more of a power issue, and that if we had more patients randomized in this study, we probably would have seen an actual significant difference, and particularly also affected by the short follow-up period of this study. Now, the next study to talk about with regard to pediatric mixed states actually looked at Risperidone. And Risperidone is probably one of the most studied second-generation antipsychotics in pediatric patients. Now, what you notice here is that there is improvement associated with the middle dose as well as the higher dose. But what's probably even more important is the fact that the tolerability changes substantially as you increase the dose without really seeing a clinical advantage in terms of symptom reduction. So what we see here when we're looking at extrapyramidal symptoms is that in the 3 to 6 milligram per day range, almost a quarter of the sample experienced significant extrapyramidal symptoms, relative to only about 5% of patients treated with the 0.5 to 2.5 milligram dose. Also, you see the prolactin data there, and again, following a very similar trend to what we see with the extrapyramidal symptoms. So in general, what we see across pediatric studies looking at second-generation antipsychotics is that, again, as I mentioned in the first portion of this presentation, the risk of hyperprolactinemia is both different relative to adults and also higher. So what we see is that certainly for hyperprolactinemia and extrapyramidal symptoms. All right. The next medication to talk about with regard to randomized controlled trial data in pediatric mixed states is Olanzapine. And what was observed here is that there is a significant difference with regard to Olanzapine and placebo on the primary outcome, the change in the Young Mania Rating Scale. But what's also important to remember from a tolerability standpoint is that there was very significant weight gain associated with the Olanzapine, and also in this sample, although not shown on this slide, there was very significant hyperprolactinemia. The modal dose was around 10 milligrams, plus or minus 5 or so in this study, so a little bit lower than what we tend to see in some of the adult mania studies. All right. So our next fact or fiction question: adults are at greater risk for metabolic effects of antipsychotics compared to children and adolescents. Fact 1 or fiction 2? So we have some things to talk about. All right. So pediatric patients are actually at greater risk for many of the metabolic effects associated with antipsychotics in adults. With regard to the metabolic effects of these agents in the pediatric populations, certainly we're aware that they cause weight gain, they may be associated with dyslipidemia, increases in blood pressure, hyperglycemia, etc. Younger first episode children as well as adolescents seem to be at greater risk. And what we also know is that second generation antipsychotic associated weight gain in this population is greatest with Olanzapine, followed by Clozapine, then Risperidone, followed by Quetiapine, Aripiprazole, and Ziprasidone. Now, currently, expert consensus statements recommend switching to an antipsychotic medication with lower metabolic liability to address antipsychotic associated weight gain. However, it is important that there are a number of other off-label interventions that have been successfully used in adults as well as in pediatric populations. And for probably about a decade now, in Cincinnati and other places, we've been using metformin to attenuate antipsychotic weight gain in those patients that seem to be at greatest risk or those who have demonstrated early weight gain associated with that. And at our department, we have a patient-centered outcome research initiative project funded by PCORI looking at the effect of metformin in attenuating some of this antipsychotic-induced weight gain. Again, that is off-label. Also, behavioral and pharmacologic interventions are available to manage these adverse effects. But we often see significant barriers associated with these, particularly in the adolescent population. So that's all I'm going to say, actually, about mixed features associated with bipolar depression, although I'm hopeful that we'll have a chance to talk more about that in the discussion section. I'm going to turn things over again to Dr. McIntyre to talk about mixed features in adults.
Thanks, Jeff. Thank you. Okay, pick this question up if we will. The presence of obesity in the adults presenting with depression should be considered a probabilistic factor for bipolar disorder and mixed features. Okay, interesting. I would probably tend to agree with the fact. Next one, bring the slide over. Fact it is, very good. Next one, and I'll say a few words about that now. And this seems to be the case, and I'll speak to this. I had mentioned during the first presentation that an impression that is been reported on around the world is that we are seeing more and more mixed presentations. And I guess we should probably, Jeff, just say a few words about what we mean by mixed, because mixed has been, if you will, it's been variably defined over the last, well, frankly, 100 years, 200 years, but in contemporary psychiatry in the last 20 years, it's seen different iterations. And in 2013, the DSM-5 took out the entity mixed states, which was the co-occurrence of mania and depression, and supplanted that with so-called mixed features specifier. And simply put, if a patient has mania or hypomania, or they have depression, and they have so-called opposite polarity symptoms, 3 or more of them, that would fulfill the criteria. Now, there are some specifics as to which symptoms are allowed and not allowed. And that's fine, and that's certainly good DSM-5 based practice. The reality, however, is that most people who have mixed in the adult population present with a lot of anxiety and agitation, which don't count actually towards the definition. And we have been looking at this for many years, and as a way to have a cheat sheet in your office when you're busy, one of the cheat sheets that I like to mention is to think about the 5 A's. So the person who has mixed is often very anxious. That's one of the A's. The next one is they're very agitated. The third one is they're very angry. These people have a lot of anger. And I don't mean just irritability, anger, real anger. Anxious, agitated anger. They also have a lot of problems with attention. Now, they come in, they're very distracted. They often ask, do I have ADHD? And so on and so on. And so they have that real attentional problem. And they also have anhedonia, absence of pleasure. So they're anxious, they're agitated, very angry. Problems with attention and anhedonic. They're sort of wired and tired. And this is really, really common nowadays in adults with bipolar disorder. And we're trying to understand why this is seemingly happening more often. And there's not a simple explanation, and it would simply be a hypothesis. I don't think we've got a verdict yet. But we do, in fact, have replicated studies that indicate that the person who is bipolar, who is obese, is more likely to present with mixed states or mixed features. And on this, oops, a daisy. Come back one slide, guys. I thought that was my pointer. on this slide at the bottom here, what we have is DSM-5 criteria, depressive mixed. And you can see different percentages. My message is that people who have obesity in the adult age range are more likely to present with those 5 A's. And what's interesting about that is that when you look at the brain of people who have obesity, their brain is different than the adult with bipolar who's normal weight. And more specifically, the regions of the brain that are different are the regions of the brain that subserve cognitive functions, that subserve affect regulation, that subserve aspects of reward. In other words, some of the areas that we think are subserving those 5 A's that I enumerated. There's lots and lots of literature now to show that obesity is in fact a brain hazard, particularly as it relates to brain volume. It's true, as your waist gets bigger, your brain gets smaller, unfortunately. Someone said to me once, size doesn't matter. So when you look at actually circuits, the circuits in the brain, the functional interconnectivity of the brain begins to change. We did a study in China, in Guangzhou, where I also have an appointment. These were children who were high risk. So these are children whose mom and or dad has bipolar disorder. As far as we can determine, these kids don't have mental illness yet. But what we did was we conducted MRI scans of these children, and we also conducted cognitive measures. This is the matrix. And what was interesting is that we found in these young kids who were at risk of bipolar disorder, we couldn't really find a whole lot of changes in their brain anatomy and or their cognitive functions. But when we looked at the sample of kids who were obese, their brain looked a lot different. Their brain had significant changes in discrete regions of interest, but also they exhibited significant cognitive problems. And we went into this, as you might guess, with a hypothesis that the young child who has bipolar disorder has 2 phenotypes, bipolar and obesity, that are not occurring by chance. And we wondered whether or not that obesity, because of this occurrence of the effect on brain, is increasing that child's risk of later declaration of bipolarity. We started to look at cognition in my center many years ago for reasons you know. It is an enemy of the state, cognitive problems and mood disorders, and we don't do a good job treating it. In fact, we probably do a great job making it worse with many of our sedating drugs. Obviously, these things can be modified to some extent for patients who've got low thyroids. I talked about earlier how more episodes increase cognitive decline. The other part to this is the consumption of marijuana. No one needs to be told that there's been a massive uptick in marijuana utilization. And in Canada, when recreational marijuana became legal about 1.5 years ago, and we've seen a massive uptick, not just in the patients, but in the staff. It's been unbelievable. Anyways, but THC and CBD, they're not ready for prime time in this area, that's for sure. And recreational weed seems to be bad news. But let me, in fact, come back to this story. So in keeping with the view that the metabolic pathways are relevant to brain health, brain disease, and more particularly brain cognition, we decided to test a hypothesis. So what we did, this is a study from my lab, where we gave these adults with bipolar disorder, we gave them a diabetes drug. These are people who are not diabetic. These are persons with bipolar disorder, and we think bipolar disorder is a consequence in part of metabolic perturbation. We gave them a drug that's better known as Victoza, which is a diabetes drug. It's known as liraglutide. And we looked at the effect of this metabolic drug on their cognitive abilities, and we were able to show that it improved it. So just as a comment, that's off-label. We're doing this experimentally and so on. But it would not be uncommon in my clinic to actually give patients liraglutide to improve their cognition in bipolar. That's all off-label, very experimental. And we did an MRS study as well. We showed that there was changes in the brain chemistry that were tilted towards a more favorable neurochemical signature. This was interesting to us because we've struggled so much to treat these cognitive problems. We're also looking at anti-inflammatory approaches to try and improve cognition in bipolar, because we think if you can better deal with cognition, not only will that have effects on the patient's PROs, patient-reported outcomes and function, but we also think that the disturbance that we see in mixed, that mixed presentation of irritability and all this disorganization, in fact, has a grand conductor. And one of the grand conductors in this is, in fact, cognitive impairment. So we're looking at this from different perspectives. Another perspective is to use prebiotics, probiotics, antibiotics. Are they ready for the prime time? No, not really. We just published a paper looking at the gut, the biota in the persons with bipolar disorder. They had decreased microbial diversity in their bowel. This is part of a larger story looking at gut-brain axis, which is receiving more attention. But I do not see, really at this point, we can say that we have established that anti-inflammatories, or certainly gut biota manipulation, is ready for clinical recommendation. But we have shown that minocycline, one of the antibiotics, which is also anti-inflammatory, is also quite helpful in some cases mitigating depression. Major depressive disorder with mixed features or subthreshold hypomania is common. This is one report looking at a study we did, and what the point of this slide is that there's two types of depression. Obviously there's not two types, but for the purpose of this illustration of point, my typology is there's two types: major depression without those 5 A's I talked about, and major depression with those 5 A's. And in the latter, that is the depression with mixed features, they tend to be more severe. They tend to be much, much more likely to be talking about suicide. And they just don't respond as well to conventional SSRIs and SNRIs for reasons that we're just not that clear about. So mixed features, which by the way affects around 1 in 4 adults with major depressive disorder, be vigilant for later declaration of bipolarity in that group, but the majority retain the diagnosis of major depressive disorder. The Florida guidelines for depression are free of charge. They're available online, and they're going to be updated again this year. This was the first guideline I'm aware of, in fact, that had a consensus agreement that in some people with major depressive disorder, not bipolar, major depressive disorder, who have mixed features, there could be an argument to be made in some cases to consider a second-generation antipsychotic as the core treatment, and or lithium as the core treatment. And certainly, as they say, more work is needed and the evidence base is thin, but every experienced clinician knows for a fact that when a person with major depression comes in and says, I'm really agitated, I'm really anxious, I'm really irritable, my mind races, I can't slow it down, you do a good history, there's no hypomania or mania that you can ascertain, these people just don't do as well on conventional antidepressants. And I thought that you'd find that interesting. Lorazepam was studied in major depression with mixed. So this was adults who do not have bipolar disorder, at least not yet, and I would argue most won't, but they have MDD mixed, and they actually received lorazepam or placebo, and we saw a significant advantage in favor of lorazepam, and the dosing's much lower, 20 to 40 milligrams a day. That would be one line of evidence. That's not 100 lines of evidence. That's one line of evidence that would support what we saw in those guidelines. We've looked at mix from different perspectives. Olanzapine has been shown to be effective in bipolar depression with mixed. I haven't initiated olanzapine in many years because of the obesity and the diabetes risk. There are alternatives, but this data is there. Cariprazine we looked at from the point of view of mania and depression with mixed features, so both poles. Cariprazine has now been shown to be effective not only for mania and depression, but mania with mixed and depression with mixed. And this is a relatively newer atypical. We looked at lorazepam in adults with bipolar disorder. Remember I showed you major depression mixed. This is bipolar mixed. Lorazepam had this ability to attenuate the mixed symptoms in the bipolar depressed patient with mixed. So you can hear the theme that's emanating and surrounding some of these slides, that it appears that atypicals, not as a class, but some of them that have been looked at in this area, in fact, have the ability to attenuate that activation, that over-arousal, and of course, giving priority to treatments that do not cause significant weight gain. Okay, so we're not going to read this conclusion slide. You have it there for us. I think we're going to do the Q&A cards.
Sounds good.
Okay.
All right. Let me go ahead and take a couple.
Sure. Yeah.
All right. So I'll start with some of the child ones while some are being sorted. So one of the first questions was, many elementary school children under the age of 10 may present with disruptive moods, severe aggression. What would be your choice of medications as well as doses? So I think probably first stepping back and figuring out, particularly in this age range, what exactly is going on diagnostically. And, you know, unfortunately, I think sometimes when we see irritability, aggression, we often think bipolar disorder spectrum. However, what we know is that particularly in the under 10s and particularly in the under 5s, wherein we have difficulties with verbal expression and abstraction and other neurodevelopmental things that need to be considered with that age range, they can often be symptoms of depression or anxiety or ADHD. So I would think about the more common things being more common. With regard to those, not to make this an ADHD, depression, anxiety lecture, but I think dosing of medications is critical in treating these disorders, and we often see patients who are failing to respond because of inadequate dosing. So if you're using mixed amphetamine salt for ADHD, making sure that you're at least at the 0.6 milligrams per kilogram range. If you're using methylphenidate, making sure that you're using at least 0.8 milligrams per kilogram. And then if you're using alpha-2 agonists, making sure that you're using those at the right dose. If I did think that this was bipolar disorder based on episodic fluctuation of the symptoms, I would probably still use a second-generation antipsychotic, although in this age range, again, off-label, I would probably be using lorazepam or aripiprazole. The question asked about dosing of those. For aripiprazole, I would probably start at 2 milligrams and tend to be a little bit lower in terms of my upper limit, probably around 10 to 15 milligrams for lorazepam, starting at the 20 milligram dose. And then again, remembering on label 10 to 17 for bipolar disorder, going up to 80 milligrams. I can take another one, unless.
Absolutely.
So, a question that really is a great question. It seems odd to use Olanzapine-fluoxetine combination to treat bipolar and yet recommend against using antidepressants. They asked me to elaborate a bit on this. I think this is actually a really interesting question. And it raises the possibility potentially that the benefit that we're seeing in the Olanzapine-fluoxetine combination is attributable to the olanzapine rather than the fluoxetine. It also raises the possibility that some of the potential hyperarousal or activation associated with the fluoxetine is mitigated by the concurrent treatment with a second-generation antipsychotic, like we see in some of the older literatures with regard to paroxetine and lithium in adult patients with bipolar disorder. Dr. Mack,
okay, a couple questions here. Are lipids and glucose dysregulation in bipolar, is it secondary to the medications that are often prescribed, or is it part of the illness? And the answer is both. It's a great question. So in people who have not been exposed, they're medication naive, they also, on average, have a higher rate of metabolic abnormalities. And in the first degree unaffected relatives of people who have bipolar disorder, the first degree unaffected relative also exhibits metabolic alteration. So we do think it's part of the illness, but absolutely, some medications, not all, are more likely to further disrupt lipid and or glucose homeostasis. A question came in here in terms of, well, many questions. Do I think that the risk of dementia is similar in bipolar 1 and bipolar 2? That's a great question. Don't know the answer to that because that's not been looked at with that level of granularity. Most of the work has looked at bipolar 1, and the reason is because it's a bit more homogeneous as a phenotype, but the proxy of episodes is often hospitalization for mania, and that's when you're doing studies, that's a much easier proxy. I love the question because it appears that on average, the bipolar 1 patient may have more cognitive impairment in general than the bipolar II patient. However, the differences between those two groups is less pronounced once you adjust for psychosis. Said differently, the adult with bipolar I who hasn't had psychosis, their cognitive deficits are a lot like the person who has bipolar II.
So there's a really interesting question, again, prefacing this with off-label, discussing the possibility of TMS, because the questioner noted that it works well. In terms of the data for that, we certainly have open label data from Paul Corkin's group and others at Mayo and at UT Southwestern. There is a trial that's been completed in children and adolescents with treatment-resistant depression, not specifically looking at folks with bipolar I depression, but that is currently with the FDA, and we're really awaiting the results of that trial. So.
Okay, is psychosis more common in older onset bipolar? On average, yes. Cariprazine, is it a first or second line treatment in bipolar depression? It's going to be a first line treatment in the Florida Medicaid guidelines for bipolar depression, along with lorazepam. One other quickie here is late onset bipolar disorder can predict bad outcomes with regular treatment. That's a very good point, and I just want, if I understand the question, later age onset bipolar disorder, that is the first declaration of bipolar disorder after age 50, for reasons that are not entirely clear, these individuals don't appear to respond as predictably or as robustly with the treatments that we know are FDA approved in the area. And the hypothesis is that there's a different biological type to their illness. And there's an overrepresentation of cerebrovascular disease, and perhaps that's not just making the point that it's different, but maybe that's changing the molecular environment of the brain so that it's not perhaps cooperating as well. But I don't, with treatments, I don't in fact want to give people the impression that people who have a later age at onset bipolar disorder don't respond to treatment. They certainly do. They just appear to have a more complex phenotype.
So the next question was related to young patients presenting with aggressive behaviors in whom we highly suspect bipolar disorder. What would be my first-line treatment, lithium or an atypical antipsychotic or second generation? In this age range, I probably would still use a second-generation antipsychotic. There are a couple reasons for that. One of which, when we look at the COLT data, which again did look at this age range, and we would be on label for lithium in this age range, it was often very difficult to get to the target levels. Now, in the COLT study, and this information has now been added to the package insert for lithium, the dose that we really, or rather the blood level that we really pushed to was 1.2 to 1.4 milliequivalents per liter, so considerably higher than Dr. McIntyre alluded to in the older population. One of the other issues is that the creatinine clearance in this population is so fast that it's often very difficult to get to a therapeutic lithium level in the under 10 population. And it also makes it more difficult to interpret the lithium level without doing some of more of the PK modeling that we do in our research group. So that's really the main reason why I would probably use a second generation antipsychotic in that population.
Would I recommend a small dose of lithium for a unipolar patient who has dementia? The short answer would be no. I'd have a hard case to defend that in terms of, let's say I was before my examiners on my certification exam, because they would say, what's the evidence to support that? And I'd have to say, none. But what I would also say is, collegially, just talking conversationally, the question's an excellent one in terms of, is this possible? I made reference to a study that was done, it was done in Brazil actually, in people who have MCI, mild cognitive impairment, and they were given lithium for a period of up to 6 months or placebo, and it appeared that the lithium had some favorable influences on their biomarkers of phosphorylated tau and amyloid. So that gives reason to believe that maybe in fact lithium could be considered, but I don't think at this point we could say it's a prime time treatment. Does lithium cause cardiac remodeling? Not that I know about. That's a very interesting question. But lithium does appear to reduce cardiovascular mortality in bipolar. And then there's one question, so another quickie here. Is it possible that the dementia in bipolar disorder is a consequence of the medication? So kudos to lithium, but do other treatments, in fact, increase the risk of dementia? It's a great question. You probably have heard that there's been observational studies associating benzodiazepine exposure to elevated dementia risk. More recently, there was a report that came out, got a lot of press actually, that anticholinergic drugs, or drugs that have anticholinergic properties, some of our antidepressants, for example, are increasing the risk of dementia later on. Again, these are observational studies. The conclusion, you can anticipate what it is. It's an association. We don't have causation. More work is needed. So I guess we're sort of left with kind of not knowing. But it's a nice point to raise. Certainly for me, and this is kind of a circuitous set of associations, but I've tried to avoid obesity-prone drugs when I can for reasons that are abundantly obvious, but also because the obesity, we believe, what we know, is anti-cognitive. So it seems to me counterintuitive to be trying to preserve somebody's cognitive abilities and then giving them treatments that cause a lot of weight gain. That just didn't make any sense to me.
So there's a question related to gynecomastia in an 8-year-old boy associated with medication. And again, I think this really drives home the issue of trying to avoid many of these medications that are associated with hyperprolactinemia, which probably relates in part to my answer on the earlier question with regard to the younger child using medication that actually is a partial agonist. And again, just emphasizing, as I've now said a couple times, that some of the medications that aren't associated with the hyperprolactinemia signal in adults seem to be associated with that signal in kids. There's another question related to a patient with severe depression. The questioner specifies, but no mania. Would you recommend lithium, or what would be your approach? I think lithium is certainly something that could be considered, although the evidence in this population is pretty limited, essentially consisting of open label or retrospective data. I think my approach here would be the standard in terms of first-line antidepressants, but again emphasizing dose as well as exposure, the two not necessarily being directly related. I would also consider adjunctive aripiprazole, lorazepam, and then from a risk-benefit standpoint would use omega-3 fatty acids. The dose there really being important, being at least 1.8 grams per day of the EPA plus DHA. Also considering that you're optimally managing the comorbidity in terms of anxiety, and then specifically looking at sleep. I think Tordia, the treatment of SSRI-resistant depression in adolescents study, taught us a lot about what not to use to manage pediatric sleep, particularly in patients treated with fluoxetine, venlafaxine, and paroxetine.
Questions here are a lot around neurocognition, and this question was, does lifetime treatment mitigate the risk of neurocognitive deficits? Great question. Multi-episode bipolarity is associated with a higher risk of dementia. The use of lithium reduces episode frequency, and that seems to reduce the risk of dementia back down to the general population level. Similar question, but different. A patient, in fact, has depression, is prescribed antidepressant, begins to show some hypomanic symptoms. Is this person at higher risk of dementia? I don't know the answer to that, but hypomanic symptoms induced by the antidepressant is, in fact, probably the best pharmacologic dissection of bipolar you're ever going to get. That probably is a subsyndromal person with bipolar disorder, or a person with subsyndromal bipolar disorder, and we know multi-episodes linked to dementia. Final question of this batch is, have you ever used lorazepam for bipolar 2? Great question. I have, and I use it plenty in bipolar 2. You know that bipolar depression is predominantly a depressive illness, and when you put bipolar 1 and bipolar 2, you juxtapose them together, bipolar 2 is considerably more depressive. So I do use the lorazepam in bipolar 2. I should mention the studies were done in bipolar 1.
I think we're probably almost out of time for questions.
Yeah.
I think it's right now 9.
Good. Oh, we're 9 o'clock?
Looks like we have 28 seconds. Okay.
Squeeze more one in.
Let's see. Go ahead. I don't have a fast one.
Okay.
Let's see. This is a great question related to placebo response, and the question is essentially, given that many of our treatments are short-term, or rather these trials are short-term, can we really infer that the treatment effect that we're seeing is due to the medication and not placebo? I think that we can, and that really becomes a question of causal inference, which I would absolutely love to have with the person that asked that after this presentation.
Folks, thank you very much for participating. Enjoy the rest of your time here, San Diego.